Hello everybody, this is Eric Chaconis for Orthopedics, Musculoskeletal 1. We're going to talk about the elbow today. So we'll get right into it here. We're going to go over kind of some different diagnoses and provide you with a little bit of an overview for the most common elbow conditions that you're going to see. Lateral elbow tendinopathy or tennis elbow is going to be the first thing we're going to talk about. You hear people refer to this as tennis elbow, lateral epicondylitis, lateral epicondylgia, just meaning pain around the area of the lateral epicondyle. Basically what they're talking about is a tendinitis or a tendinosis of the ECRB, ECRL, or extensor digitorum, where they attach on the lateral epicondyle and supracondylar ridge for ECRL. So you get basically stress going through those tendons, and they'll become inflamed or they'll become degenerated. You got to delineate between whether it is a tendinitis or a tendinosis, basically whether or not there's inflammation present or not. You also got to be able to specifically identify which tendon is affected. So you want to be more. My point is, you want to be more specific. Don't just say lateral epicondylgia, lateral epicondylitis. Say, I think the patient has an ECRB, ECRL tendinitis, if those are the tendons that you incriminate. It's usually going to be just too much stress. There's a biomechanical underlying impairment, like let's say you get somebody that has limited joint mobility of the elbow. Then when they function and they move their elbow and their arm, they put abnormal stresses through those tendon tissues and they get inflamed and irritated that way. You can also get issues where you have maybe a shoulder mobility problem or shoulder strength issue. You have weak grip strength, weak distal strength around the wrist and hand, and that'll just transmit forces and you'll get an excess of force in the elbow, and so that'll cause it too. Usually it's microtrauma, repetitive, small bouts of trauma that irritate it. To diagnose this patient, so you really want to try to contract that tendon, right? So your best test to try and incriminate this tissue-specific impairment is going to be probably an MSTT, because you're going to want to contract it. And as soon as you contract that tissue, if you feel like it's a strong and painful contraction, then you're thinking to yourself, okay, it's got to either be a tendinitis or a tendinosis. I'm going to go back to palpation for condition and determine which one it is. Another good option would be to stretch it, so muscle length test, right? If you stretch that specific tendon and it reproduces their pain, that can be diagnostic. And then if they have specific palpation for tenderness right in the area of that tendon where it attaches at the lateral epicondyle, that's diagnostic as well. In addition to that, you have a few special tests. Now, these special tests are very similar to some of the other tests that you're doing. Like, for instance, this test method 1 for lateral tendinopathy, it's called the Cosen's test, or lateral epicondylitis test 1. It's basically an MMT of the wrist extensors, right? So you're putting them into wrist extension and radial deviation, and then you're trying to get them to contract, and you're trying to pull them out of that position. Well, that's really just trying to get a strong contraction of that tissue to see if it reproduces their pain. Mills test is like an MLT. So Mills test, you're just really putting the tendon on a stretch position by flexing the wrist, extending the elbow, and trying to pronate the forearm a little bit. And then when you do that, you put them in that position where it really stretches it, and if they have pain right over the area of that lateral epicondyle, then it's probably diagnostic. And then test 3 is essentially an MSTT. You're trying to contract extensor digitorum by getting over that third digit distal PIP, and you're trying to kind of fire those wrist and finger extensors to see if that's painful as well. If your clinical exam was not conclusive, you really weren't able to get those definitive findings like we just described, then imaging may be indicated. It may be helpful to help you make a diagnosis. And so on the left here you have an ultrasound image, and what you see is the lateral epicondyle is the bone tissue right here. You see that bright line, that's the cortex of the bone. And then where that extensor carpi radialis brevis attaches there on the epicondyle really should be a nice flat tendon tissue, seeing it going in a kind of linear fashion, and you see this pocket of fluid right there, and so you know that tendon's inflamed, it's starting to break down a little bit, there's pockets of fluid within the tissue. That's abnormal. You can see it on an MRI here, so you see on the MRI, you see right where that tendon attaches at the epicondyle, it's bright signal intensity, there's some fluid in there, you can see it there on the right as well. So MRI and ultrasound can be helpful. Usually you don't need that though. Lateral epicondylitis is really pretty easy to diagnose. All right, from a management standpoint, and this kind of goes for all tendon problems that we're talking about here, right? You just want to make sure you treat the underlying impairments. So if there's any biomechanical problem that you think is contributing to it, like the things I talked about before, elbow mobility, shoulder strength, grip strength, then those are all things you'd want to treat to try to correct the cause of the problem, right? Generally speaking, when you have these tendinitises, they're swollen and reactive conditions. You want to do what you can to decrease the stress, really try to slowly facilitate healing, calm it down, basically. So sometimes cortisone injections and nonsteroidal anti-inflammatories can be helpful. You can put, some people like to wear these straps around their elbow that help take some of the stress off the tendon, and then various modalities. If you have a tendinosis, it's really a different treatment approach. It's not swollen, it's not reactive, it's really something that's kind of broken down and weak. And so you really want to try to stimulate healing, really get that tendon stronger, right? So doing different types of manual therapy to try to stimulate tendon healing, really trying to load it, right? You want to really do good, strong, concentric and eccentric exercises to really put good stress through that tendon, which will help facilitate healing. PRP is platelet-rich plasma. That's a medical procedure where they take your blood, they spin it in a centrifuge, and then they inject your blood back into the tendon tissue to try to stimulate healing. So sometimes that's an option. It's debatable whether or not that's effective. And surgical debridement, I have had some cases of patients that didn't get better, and I referred them to a surgeon. They got it debrided, and they ended up doing pretty good long term. So if they fail all other conservative measures, that can be a last resort option. All right, on the medial side, you're basically dealing with the pronator teres, flexor carpi radialis, flexor carpi ulnaris. And it's really the same deal. They call that golfer's elbow. Sometimes on the right arm in a right-handed golfer, you'll get a little bit too much stress from hitting the ground, hitting fat shots. And but honestly, I don't think it's a very common golf injury. It's not something that we see quite often in golfers. It's just one of the slang terms to describe it. But it's the same deal as far as diagnosis goes. Same thing. Contract those tendons, put those tendons in stretch positions, palpate that medial epicondyle for your diagnosis. Posterior is the same exact deal. You're just talking about the triceps. All right, so changing gears, totally different pathology now. We're talking about really is the joint itself. What you get at the elbow is a very common thing that can occur post-surgery, post-immobilization, post-injury, is that the whole thing will get real tight. The elbow is a pretty stable joint typically, and it can get tight pretty easily if you have one of those situations. So what you want to look for is a capsular pattern. The capsular pattern for the elbow is that flexion is going to be limited more than extension. And if you kind of try to match the arthrokinematic movements to that, the accessory movements to that, for the radial head, it's concave, right? The radial head is concave, moving on a convex humerus. So if you're talking about flexion and the radial head is concave, then that's obviously going to move in the same direction, right? Concave-convex rule tells you that the concave surface is going to move in the same direction as the limb. So if the limb, when I flex my arm, is moving forward, the forearm is moving forward, then it's going to be an anterior glide, right, of the radial head, because the concave surface is moving in the same direction. It's also moving forward arthrokinematically. So an anterior glide of the radial head is going to be limited more than a posterior glide. You can get other joint injuries to your elbow, namely the ligament on the medial side is most susceptible. So the medial collateral ligament of the elbow, you see this a lot with overhead throwing athletes, baseball players in particular, and more specifically pitchers oftentimes. And it's just so much stress going through the elbow, going through the medial side of the elbow with the throwing motion. They end up getting breakdown of that medial ligament. It's really one of those things where they're just baseball players are getting so strong nowadays, and their core is strong, their hips are strong, shoulders are strong, and so the ligament's just unable to handle all that force. And so that's kind of what results in in the medial collateral ligament laxity. To diagnose that, really, it's a valgus stress test. So grabbing that elbow, putting a valgus force through it, and feeling increased mobility. I mean, that's a special test that you're going to do in lab. Feeling increased mobility with that test would be diagnostic of a MCL sprain. The other thing is, like right where that ligament sees, you can see that arrow right where that ligament is. If you palpate for tenderness right below that medial epicondyle, between the medial epicondyle and the ulna, you'll feel tenderness right around that. You'll get tenderness right around that ligament, and that's diagnostic as well. The median nerve. So median nerve entrapment can occur really in a number of locations. And so you go anywhere up as proximal as the cervical spine, right, where the nerves of the brachial plexus come out from the spine and pierce through between the scalenes. You can get compression in those scalenes up there as it courses down, and you see all those trunks and branches split off, and you get the median nerve coming down the front of the elbow and the forearm, and it runs underneath pronator teres. It'll get entrapped right there at pronator teres. More proximal to that, this is kind of a rare one, this ligament of Struthers, where the nerve can get entrapped there. You don't see that very often. There's a small percentage of people that actually have a ligament of Struthers and where that nerve runs underneath of it like that. But that could be one source. Not really much you can do about it, but that could be one source. I think the most common ones you guys want to think about really are this pronator teres idea here, where the median nerve comes down through the anterior forearm, pierces pronator teres in some people. Some people it runs underneath pronator teres. Pronator teres hypertrophy would certainly give you the entrapment. And then the other one is the wrist, right? So the median nerve comes down, crosses the carpal tunnel at the wrist, and that's another site of median nerve compression. We're going to talk today really just about the elbow. And so if it were to happen at that spot, at the front of the forearm, at the elbow, you're really going to expect to see every single muscle, excuse me, every single muscle that is innervated beneath that position, beneath that spot where the nerve passes the pronator teres, is going to be impaired. It's going to be weak. So all those muscles listed there are all muscles that are innervated distal to the median nerve location at pronator teres. They're all going to be impaired in some way, shape, or form. So that's what you're looking at. You're looking at a specific pattern of muscle weakness. If you see this specific pattern of muscle weakness, all these muscles are impaired, then that can be very diagnostic for you. Sensation loss, right? You know, median nerve, where it provides sensation to, I mean, it's really the radial half of the hand and the radial half of the ring finger and the palm. You get the tips of those first two fingers will be diminished sensation, but you know, it's this definitive area here. If you see diminished sensation in that location, the palm of the hand, the first 3.5 fingers, and you also see weakness of all those muscles, and you know, okay, there's got to be something going on with the median nerve. It'll split. The median nerve splits at pronator teres, and you get this anterior interosseous branch. This anterior interosseous branch can get entrapped there at the volar forearm. And so what will happen with that is if only the anterior interosseous branch is entrapped, not the entire nerve, you'll only lose motor to these three muscles: flexor pollicis longus, flexor digitorum profundus, and pronator quadratus. So it's just a motor-only nerve, anterior interosseous. You're not going to see any sensation loss. You're just going to see those three muscles be impaired. This is called the pinch grip test. And so this test, you're trying to ask them to touch your fingers tip to tip. And if they can't do that, if they come in pad to pad like that, well, that's because what's impaired? Flexor digitorum profundus, right? Because that flexes the DIP, and flexor pollicis longus, which flexes the IP of the thumb. So if those two muscles are weak because of that anterior interosseous nerve entrapment, then you know it can be diagnostic for that. All right, radial nerve at the elbow. So this is usually going to happen. The radial nerve is going to get entrapped if you have a humerus fracture. The radial nerve kind of twists around the humerus, and it sits very, very close to the humerus, the bone. So if that bone gets fractured, sometimes through the healing process and because of swelling and stuff in the area, you get a radial nerve entrapment. It can also happen down at the elbow. You'll see it at the radial head. And sometimes even people that have their arm immobilized, they have a brace or a cast on that'll compress the radial nerve kind of around the elbow like that. So the thing about radial nerve is it has two branches. And so if you get an entrapment distal to the elbow, like for instance in the supinator muscle, you're only going to get motor loss only, because the deep radial nerve is a motor only nerve, and the superficial radial nerve is a sensory only motor nerve. So once they split after the elbow, they turn into superficial radial, which is sensory only, and deep radial, which is motor only. All right. So if the entrapment is at where the tendons kind of attach around ECRB, where the ECRB tendons kind of blend into the epicondyle, the superficial radial nerve sits very close to them. It has close proximity to that. So sometimes the fibrous edge of those tendons at the ECRB, they can be a source of entrapment site for the superficial radial nerve, and you would only see sensation loss in the dorsum of the hand, the web space. The radial side of the hand, dorsum, and the anatomical snuff box is where you see sensation loss. If the entrapment site is at the supinator here, at the deep branch at the supinator, then all you're going to see is just motor loss of these finger and wrist extensors that are innervated distal to the supinator. Ulnar is the third one, and at the elbow it's going to get entrapped at the cubital tunnel. You see how superficial the ulnar nerve sits as it runs by the elbow there, just posterior to the medial epicondyle in that cubital tunnel. You can actually palpate that really easily, and it's a very superficial tissue that even just like resting your elbow on a desk for a prolonged period of time, or bumping your arm, like you feel like you hit your funny bone. When they say you hit your funny bone, that's basically you just compressed your cubital tunnel, the ulnar nerve at your cubital tunnel, and that's why you had those neurological symptoms of burning, numbness, tingling, something like that. So if that's bad enough, you'll get motor loss, and it'll just be flexor carpi ulnaris, flexor digitorum profundus, just the medial half, right, just the side that's towards the ulna. All those hypothenar muscles, and then also don't forget ulnar nerve crosses over and innervates adductor pollicis, and it also innervates the third and fourth lumbricals. What's not on there, though, is palmar and dorsal interossei, too. Palmar and dorsal interossei are also innervated by the ulnar nerve. So that'll be motor loss. You'll also get a sensation loss, right, to the ulnar half of the hand. Half of the fourth finger and then the fifth finger will all be impaired. So as you're trying to I think the main thing that you should take from these nerve entrapments, when you're trying to diagnose a nerve entrapment, really try to use that neurovascular step where you're looking at sensation and motor loss. Those are going to be your key clinical findings to diagnose these nerve problems. Now, the other thing in addition to that, so sensation, when we do light touch, motor testing, we talked about that. If we know for a fact, or if we suspect that, let's say, the median nerve is entrapped at the pronator teres, if we try to go in and palpate that specific area right over the pronator teres, that could be diagnostic as well, right? If you palpate there and it reproduces their pain, then that potentially could be a diagnostic finding for you. The other thing that you can do are these neural tension tests. You're going to learn more about these next semester in Therics too, but basically neural tension tests are putting the arm in a position where the nerve is on stretch. And so the one they're doing here is for median nerve, and basically they depress the shoulder blade, bring the arm back, extend the wrist, extend the fingers, and that puts a lot of stretch on the median nerve. And if that hurts the patient when they do that, then it can be diagnostic for that specific nerve entrapment. You also have some special tests we're going to talk about, but the main thing is you got to find out what's the cause, right? Most nerve entrapments, there's some type of mechanical cause, and you want to diagnose that as well. So it's kind of like you want to know that they have a nerve entrapment, you diagnose that, but you also want to know the contributing factors so that you can treat it properly. All right, so here's a little kind of homework exercise I want you to do between now and the next class. So on Monday, February 10th, with the elbow 2 section, we're going to go over what's called a reverse case, and this is going to be the topic. All right, so I want you to do this before class. Come to class with your answers, and then you'll be able to kind of bounce those answers off of what I'm going to go over, and we'll have a little discussion about it, help you get ready for the exam, help you practice a little bit. So, patient comes to you with an ulnar nerve entrapment. That's the diagnosis. That's the ulnar nerve entrapment, right? But the cause is due to edema in the area of the cubital tunnel, right? So that's like what I just talked about. You've got this causative factor, and it's the edema in the area, and then the result of that is the ulnar nerve entrapment. So when you think about that, you got to think, okay, I got to diagnose both of these things, right? I got to figure out how I'm going to diagnose both of these conditions. The stage of condition for both impairments is subacute. Tissue activity is moderate. So what you want to do now is you want to describe or report the expected physical exam findings from steps number 5, so that's starting with palpation for condition, all the way through step number 14 of the clinical exam. All right? So here's how you want to attack this. You want to pretend like a patient was sent to you, and they were sent to you by a friend, right? And the friend maybe is another healthcare provider. And the friend says, hey, I sent my brother over to you, and he's got some elbow pain. I want you to take a look at him. Tell me what you think. All right? So you do your eval, and then you call your brother, the friend up. And you say, hey, I took a look at your brother today, and I think he's got an ulnar nerve entrapment at the elbow, and I think it's due to edema in the cubital tunnel. So then your friend says, okay, why? Why do you think that? Right? You have to defend your diagnosis, and you're defending your diagnosis with your clinical exam findings from steps 5 to 14. So when you write those findings, make sure you write them with great detail, because that's how you're going to describe it, right, to your friend. You're going to describe the findings that you had that for your purposes made the diagnosis. All right? So do it with detail. And also, the other thing to think about is be really straightforward, right? We're only talking about an ulnar nerve entrapment due to edema in the cubital tunnel. Don't add other stuff. Don't make other stuff up. There are no other diagnoses. Those are the only diagnoses. So answer it straightforward. When you practice that, we will go over it, like I said, on Monday when we get back. So good luck. Thanks for listening.